Thanks a lot, Dobranic, to all of you. I admire your stamina that late in the evening you are still attending this meeting after a hard day of work. I just wanted to mention that Volodymyr Korosti, professor of Charkiv for psychiatry, and we are technical advisors to Médecins du Monde Greece. And tonight I'm going to tell you a bit about some new developments in our field. And here on the left, you see a picture that shows that we all stand on the shoulders of previous generations, like the next generation will stand on our shoulder. And you also see here this public health pyramid that we all have to learn, appreciate so much over the past years, which in fact was for the first time described in 1920 in Science. So don't worry, I'm not going to talk about the past 100 years. I'm going to give a brief update on our field. And I'll talk first, show you some of the evidence, the guidelines, and the intervention tools that we have been developing. A lot of what you've seen already. Then I'll mention a few research themes that have been coming up over the past years, and I'll formulate a few challenges for the future. Now, we do have new treatment evidence, and especially for adults, less so for children, and mostly for common mental disorders. And we try to develop evidence-based interventions that are brief, that are manualized, that are scalable, that are culturally adapted, that are transdiagnostic. Most of you will know what that means, but just to explain this, it transcends the different diagnoses of depression and anxiety and PTSD and other issues. We aim at sustainability with our interventions. We go along the mental health professionals, and the most widely known, you see them in the next slide. And this is where my computer always, so it is here. On the left, you see the MhGap and the PM Plus that Lydia is going to talk about. Ease for children, which is the equivalent of PM Plus for children. The interpersonal therapy, the self-help plus integrated in common elements, community-based social therapy, and psychological first aid. And I put a circle around the psychological first aid because what I wanted to mention is that though these interventions are evidence-based, it doesn't mean we all have to trust them blindly. For example, I myself, I'm quite critical about PFA, although I was a co-researcher on the only randomized controlled trial that has been done on PFA in West Africa. And why am I critical? Because I think in many cultures, and also to some extent in Ukraine, what I've seen so far, people do many things automatically or more or less automatically when there's massive distress. They listen, they are empathetic, they are compassionate. And then sometimes we as interventionists, we come in and we say, well, it would be good if you would be compassionate and empathetic and if you would listen very well to other people. And then the people say, well, what's this about? We have been doing that all along. So while we want to empower people, we may also disempower them. So I think psychological first aid is very useful in some contexts. I think it's especially useful in contexts where there's a lot of masculinity, like among the military or the police or emergency service people. But that was just a caveat when it comes to evidence-based, that it doesn't mean that it's automatically proper for the context we are working in. And in many of these interventions, of course, they were mentioned during the recent conference in Kiev. And here you see a number of these manuals that have been developed over the past years, where the task is always that we have a global toolkit here on the left with these different manuals, the MhGap, the PM+, but we always have to build on the local. And that's still where I think a lot has to be done in Ukraine, which is a challenge to all of us. One of the beautiful things that we have now is this mental health and psychosocial support network that we can all use to see new interventions, new trends. We have the minimum service package that's now also used in Ukraine, developed by the UN. And I would like to spend a few words on two interventions that are less well known, but which I think are very useful for Ukraine. And one is Reshape and the other one is Gears. And what is Reshape about? On the left, you see how we normally do MhGap. We train health workers, we supervise them, they know how to use the algorithm, the decision tree, and that's how we do the job. But in many contexts around the world, and especially when there is stigma among the primary care workers, the primary care practitioners, and I think stigma is very, very high in Ukraine. I've done this work in more than 35 countries around the world for short or longer periods. Stigma, I think, is extremely pronounced in primary care settings in Ukraine. And that's where Reshape would be an option to use and to roll out. And we are planning to do that over the next year. And what is Reshape about? Here you see again the way we do MhGap normally. We have specialists or trainers that train primary care workers. But now here comes the Reshape. What we do is we have meetings between service users or people with lived experience of mental illness, as we call it, and aspirational figures, which are in fact primary care role models, primary care doctors and nurses that are very good in MhGap or PM Plus and like to do it. And they give introductions to mental illness. They together present recovery stories. They participate in question and answer sessions of about 45 minutes. So after the normal training of MhGap, at the end of the day, there are about 45 minutes where service users together with the practitioners, where they sit together, where they have questions and answers. And I'll tell you a bit more about that in the next slide. So to decrease the stigma among the primary care workers, you organize social contact interventions where the stigmatized group, the service users, and the stigmatizing group, so sometimes the primary care workers, where they interact through sharing stories and where they come together and where they have collaborative activities. They tell the stories about how they felt before they went into treatment, during the treatment, and after the treatment. They meet the primary care workers who like to work with people in mental distress, and they have different techniques like photo voice narratives where they tell about their lives. And then they have a number of activities with the primary care workers, like having a dinner and a meal and a drink, and that may involve the community. So that's very brief. That's the Reshape intervention, which I think could be a very, very positive add-on to the MhGap work that we do, because we know from many different situations around the world that just training people in MhGap, like the 30,000 plus people that have now been trained in Ukraine, it doesn't necessarily mean that things get much better by themselves. The second intervention that I would like to mention is a group emotional relationship skills program for the military and veteran. I know there are several programs going on, but what I like about this Australian program is, again, that it fits within the public health structure. And let me tell a bit what it's about. It's a transdiagnostic program like PM+. It has a psychoeducational component. It's a skill-based group intervention to promote emotional, interpersonal, and functional stability. And one of the good things is that it involves the partner of the veteran or the military and the family during some of the sessions. Its theoretical framework is ACT, CBT, dialectical behavior therapy. It's manualized both for the facilitators and for the recipients. And it's implemented by co-military or co-veterans who have counseling skills, who have learned counseling skills. So it's a peer intervention. It has, again, a training of trainers model like MhGap and PM+, and it's 12 sessions. And some of the primary themes are the need for emotional understanding, also the need to understand your identity as a military or a veteran, the values and norms of the group, the regulation of your emotions instead of avoidance of the traumatic stress, normalizing the idea that trauma and stress has changed them, but not necessarily in a negative way. Rather focus on recovery than on cure treatment. So aim at improving functioning and a positive self-identity rather than pretending that all trauma will be finished. Development of effective and supportive interpersonal relationships, as I said, with the family, but also to promote a recovery process. And it's preclinical. That's why I said it fits into the pyramid. It's not on the top of the pyramid. It sits in the middle, and it does not replace or exclude personal therapy. So these were two interventions which I think could be interesting for Ukraine. And then I'll go on with quite a broad range of toolkits and instruments that we have been developing over the past years. So there is the toolkit for humanitarian settings of WHO and UNHCR. There's the very beautiful program for improving mental health care called PRIME, a big multi-country study that addresses almost all the difficult issues that all of us are struggling with to integrate mental health into primary care, how to do that, how to train the primary care workers, how to improve their diagnostic skills, how to make sure that they keep going, how to properly diagnose the people, how to make sure that patients, they follow the whole treatment and not part, etc., etc. And then there is a whole group of competency-driven training approaches where we have a number of toolkits and instruments where, for example, in the ENACT tool, we can look at what do our trainees know before the training and what do they know after the training. We have the same for children, the WE-ACT. We have a tool for group sessions and for group assessment before and after our intervention. And we have WHO's EQUIP program developed together with Brendan Court from Washington, which is a platform where you can look at how do our trainees, how do they perform before and after, how do you get feedback into your training programs. So I think this whole basket of instruments is a good step forwards over the past years. Now I'd like to spend a few words on the next theme, which is research. And I think I'll mention a few domains where I think we made interesting progress in research. You see that there is a tendency to go towards a precision psychological paradigm, meaning that instead of pretending that when we do PM Plus or Self-Help Plus or PFA or MhGap, that what we do, that it's useful for everybody, which we know is mostly not the case, we try to look at what are the subgroups that are specially helped by a certain intervention, and why would that intervention work for that subgroup and not for another subgroup. So there's an interesting number of studies here by Borgato and others from Italy. Then we have a large chunk of research on linking the Sustainable Development Goals of the United Nations to mental health outcomes. So we see studies that look at economy, at demography, on violence, on community violence, war, human rights violations, and their relation with mental health outcomes. We see very interesting research, in my view, to address the barriers to care. So what is this about? Normally, what we have done over the past years, we have developed these evidence-based interventions. So we look at what are the needs of the community. Do we need a new intervention? Do we have the evidence? Is it cost effective? And then we have this group of interventions that most of us know. But the big challenge now in humanitarian settings around the world is, how do we scale that up? So how do we go from that research phase to the implementation phase? How do we reach large groups of people? And that's an art in itself, where on the one hand, we have to look at, is it feasible what we do? Can we pay it? And on the other hand, we have to look at what we do, does it have enough quality? Do people come to our services? Do people follow the whole treatment? Do they drop out? When we train people, like many of us do in Ukraine, we talk about TOTOTs, training of trainers, but many of us, we just train one level, whereas the strength of MhGap and PM+, etc., is that we go from the first to the second level, which is from 1 to 10 trainees, and from the second to the third is 100 trainees, and then 1,000 trainees. And that's what Ukraine needs. But then there are many, many questions how you do that. And so I advise you to look at these beautiful studies by Jordan and Luto. There is the integration of MHPS and disaster risk management. I show a slide in a few minutes. We have a lot of research into intergenerational transmission of trauma. And we see research coming up, which is also very important, which of course I like as a cultural psychiatrist, is that we use psychiatric and psychological outcome instruments for depression, anxiety, psychosis, substance abuse, and we combine it with local cultural concepts, idiom of distress, and we look at how do these Western academic international instruments, how they compare with what the people themselves think about their problems. So the United Nations Interagency Standing Committee agreed in 2009 to treat mental health psychosocial support as a cross-cutting issue that has relevance, etc., as you can see in all emergencies, which is a big step forward. And I give one example. You see here on the left, you see a picture from 1970. That was about the first nightmare in my life. I was in a cyclone in Bangladesh, where in 2 days, about 300,000 people died, which is more than atomic bombs from Japan. And now here on the right, you see how this is tackled by disaster risk management in Bangladesh. All over the countries, there are these kind of buildings that are normally used as primary schools or primary healthcare centers. And when there is a hurricane or a cyclone, the population goes there. And so this death toll on average is now about 15 dead people a year. So imagine what kind of reduction of suffering that has meant. Okay, so I gave a few of these interesting research domains that have been coming up over the past years. And I want to just also mention a few challenges for the future. So one of the challenges in many places in the world is how do we balance the agenda of local actors with effective interventions, cultural adaptation, and sensitivity, which is a key issue. Like at the moment in Ukraine, many of us, we are struggling of what can we do in a certain area, asking the people in education or in the healthcare sector to collaborate, to cooperate. So how do we develop localized models that encompass all these things that we are training and that we are training each other? It means how do we develop a mental health care system taking local factors into account, which I think is a very complex issue also for the country at the moment. Then I think a big challenge for our field is also how do we assess the effectiveness of multisectoral engagement. So since about 25 years, everybody in the world, in our world says, okay, the people who work in the educational sector and the healthcare sector and the social sector and the women's sector and the economy and the legal system and the human rights sector, they all have to work together. But very few of us know how to do that. And we know even less whether that it's at all effective or cost effective. So we talk about it, but whether it's a good thing, in fact, we don't know. A third issue is that there is an enormous need for family interventions. In war times, as we all know, and you know very well in Ukraine, at the end, very often the burden of the war comes on the family. The family has to grieve, has to mourn, has to pick up their courage again, do things, get out of the rubble. And though that's very important, we see over the past 15 years about 10 good parenting interventions, how we deal with children and youth in war zones or in other difficult violent situations. But there's very little for the whole family. So there's very little that includes the parents. And by the way, there's also quite little for the teachers. So we can work with the students and the children. But how do we take care of the caregivers and how do we take care of the teachers? Then a thing that also goes to my heart is that I think we need innovative interventions in our field. And why do I say that? PM Plus and MhGap and Self-Help Plus and EASE and Reach Now and Teams Up, they're all beautiful, but they're kind of diluted psychotherapeutic interventions. And they have very small effect sizes that often evaporate over time. And since we train many, many people, and since we want to spread our interventions as an all stain over the population, from a public health point of view, that's justified because we can reach many, many people. And even though we have a small effect size, it has a cumulative positive effect on the population. But on the other hand, all over the world, there are generations of healers dealing with psychosocial issues. Most cultures, they have one healer for about 500 to 1,000 people in a population. And there is enormous wisdom that we don't tap into. We always continue our own way. So I think there's a big challenge in looking at what is culturally available and how can we combine that with our Western approaches. And in fact, when you look at mindfulness and things like that, what we do is we take elements of Theravada Buddhism in Sri Lanka and add that to our mindfulness, which is also kind of international cultural exchange. And then I think the last thing I want to mention during this talk is that this interest to do research to go beyond comorbidity and go into the field of syndemics, meaning that when there are different social problems or there are different epidemics, like there is diabetes, there's overweight, there's depression, there's post-traumatic stress, and these epidemics and problems come together and they interact and they cluster in the population, then you get adverse reactions which are either biological, think of HIV and tuberculosis, or social or behavioral, and that creates an enormous burden of disease and a burden on quality of life that's much bigger than the cumulative effect of adding up these different epidemics. So these were a few challenges in the field of research for the next decade or decades or so. And I come now to the end. Thank you for your attention.
All right. Thank you very much, Joop, for that very comprehensive overview. Brilliant. And listening into you, maybe I will start a first question, if I may, and please reach out, attendees, because I'm trying to phrase a question also on behalf of you, and help me, Joop, when you've done this for numerous years, right? As you said, you have vast experience, 35 countries and maybe more. Now, you mentioned a couple of big organizations, and you referred to the PM Plus and the WHO. Is it so that when you do these top-down interventions, that they don't reach, now I should phrase it differently, do they reach the, let's say, the end users? Or as you maybe, you said it in an eloquent way, they don't filter down. And, you know, I think that there's so many NGOs that are now doing their things in Ukraine with good intentions, but what do you think of these big organizations that, do they reach the end users in a very comprehensive and effective way? Do we need to be critical, or do we need to be supportive of embracing these initiatives? What is your appraisal? What is your appetite? Because you've been around so long, you have the best perspective, if anyone, I think, from how effective these interventions are.
I think it's a very mixed picture. When I started this in the early 90s, everybody said that I was mad, that I thought that I could do something in the field of trauma and distress in war zones. What you now see, as you said, you often see that there are like 20 to 100 NGOs coming into certain areas in the world. What I think is a huge step forward is that there are so many NGOs that are taking this up. It's a huge step forward. For example, I heard the head of the Red Cross saying in Lebanon 3 years ago, he said, post-traumatic stress can be as debilitating and dysfunctional as losing a leg, which from a director of the Red Cross worldwide to me was really stunning that he said that. So I think it's fantastic that there is so many people are involved. There's so much attention for it. I think it's also a huge step forward that we have all these interventions. If I'm very honest, I think MhGap, it's not a step forward, it's a step backwards. There are the flowchart from Britain by Essex and Gosling, which I think are better than MhGap. But MhGap, it's formalized, it's manualized, like PM Plus, like all these interventions. So the fact that not everybody is inventing, like in the old days, everybody was doing counseling. And nobody knew what counseling was exactly, whether it was more psychological or more social or more legal, whether you needed to train somebody for 6 weeks or 6 months, as some of us did, but there were also NGOs that did it for 2 days. And then they said you're a counselor. So this major step that we have these interventions, that we know how to train, that we have the manuals. Mm-hmm. And we will hear soon by the next speaker that it's not easy. You know, I'm a PM Plus trainer. It took me really an effort to learn how to deal with this manual of 150 pages. But it's fantastic, it's there. The MhGap, it's very good, it's there. So there are many, but that's why I say, if you really want to understand how difficult it is, you have to read those studies, the papers by the PRIME study. Because Ukraine now training 30,000 people, that's the very, very, very first step, and it's a very small step. And there's still 9 steps to make. And that's what we all have to realize. The real work is still starting.
Mm-hmm. 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 Thank you, Joop, for that very eloquent answer. I see, Irina, you're typing a question into the chat. Maybe you can ask the person who's asking that question to speak up. If you know who it is, would you do so?
Так, дійсно, Ерік, я вирішила запитати.
That's right, Eric. I wanted to ask the colleagues what interventions do they actually use out of those mentioned by Joop. Thank you for your talk. It opened up many rooms that I didn't even suspect existed. Thank you, Joop. I look at the faces and I see trainers of these intervention, the TOT trainers. I see recent graduates. I see people who work with us across different projects in Ukraine and abroad. So I asked a question in 2 languages and I see people writing, I am a PM and SH plus training. I am a PFS trainer. PM plus, self-help plus, first aid, PFA, PM plus since 2017, MhGap, CETA, doing what matters in times of stress. So we have here with us today the audience that is extremely well prepared to ask many interesting questions. So colleagues, we do encourage your questions.
Yes.
Good evening. Greetings, colleagues. I would like to thank you for having me. It's an honor and a privilege for me to be here today with you. I did have a look at a couple of webinars. Incredible experts, incredible content. This is helpful indeed, both for professional Ukrainian community and the others. It's a big audience, given that this webinar starts really late and it's a work day. So I would like to thank the audience for taking the time to watch and listen to this event. I would also like to thank the people who trained me and to people with whom I worked and whom I met and to people whom I helped. I'm going to share an experience with you. And I have this experience thanks to all the people I mentioned. Irina and I talked a bit, and the focus of my presentation would be practical, give you a couple of cases, examples that originate from my work in Ukraine and elsewhere. For some of you, that might be a very straightforward intervention and exchange, but I hope that it's almost 9 years since I started in Ukraine and other countries, and there were plenty of conflicts, so I hope that this experience would be useful to you. I'm going to name a wealth of examples and guidelines. The guidelines mentioned by Joop hopefully will become more palatable for you. They were brought to life for me once, and hopefully my examples will bring the guidelines to you to life as well. You see, these instruments didn't appear out of nowhere. They are there for a reason, and they're grounded in the best practices that are known to people presently. And they're also based on lessons learned and on human suffering. So these documents can come alive if you know what they're based on. Irina, might I ask you, in case I veer off, you could ask a question to point in the right direction for me, because what I'd like to start with is sharing my experience of how my journey began in this. I'm trying to share my screen right now. We will talk about mental health. You can see the slides, can you?
Yeah, perfect.
Yes.
Yes, we do. Yes, we can see the slides. Okay. Mental health of persons affected by war and other emergencies. I will focus on our programmatic activities. What can a mental health and psychosocial support professional can do across different stages of care, across different levels of care? I'll start with an example, and I'm sure you know it. I'll start from me. So this is the beginning. I initially started volunteering in a hospital back in summer of 2014. That was a hospital for wounded people. I had the therapeutic background and psychological background. I was doing individual counseling, a little bit of psychoeducation. So I thought that would be my role, and this is how I started working. And this is what happened. We had almost no experience on providing response for mass emergencies. Hardly any experience, in fact. There were so many people and I was alone. I was a volunteer in the European hospital in surgery department. So what you could do is a maximum of 2 or 3 counseling sessions, and they were exhausting. That was in the summer after the Battle of Ilovaisk took place in the east. Once I get a call of coordinator, and she said, "This is Trustim. We have an artist, a Crimean Tatar, and he wants to do something for the boys." I say the boys because back when I was a volunteer, there weren't any women that were injured in the hospital. So we have this artist who wants to do a workshop for the injured population of the hospital. And what they asked me is to create a group of the boys that would participate in Rustem, as he was called, that would participate in his arts. I didn't know him then. He's a Crimean Tatar. I'm extremely proud of him now. So he wanted to come to us and do something together. So I talked to some of the surgery patients whom I knew. So 7 people were interested as a result of our conversation. Okay, we are going to do some pottery. Let's make some cups. I had 0 idea what could that have to do with my psychology. I had a decade of training in psychology. I had honestly no idea, and I didn't know what it had to do with psychology. That was in the summer. If you visited the Irpin military hospital, you might know that before the surgery building, they have these benches outside. And we sat outside. There was Rustem with his clay, with his colors, and there were 7 people with various injuries, and they started making this pottery. I joined them a bit later after I ended my counseling session. When I saw them work as a community, they were making jokes, making fun of each other, because you might get a person with an injured hand and he had only one hand to do arts, and other people helped, and they mocked their own traumas, and they were together, they were spending time together, and they were doing arts, they were engaging in some creativity. And I was sitting there on the bench. I was thinking, was that something I could give to those people? Because it was a sense of community. They were truly empowered. And there was a practical outcome, because Rustem took this pottery, burnt it, and then returned the final products to the creators. Later, we saw a doctor approach. He was, this surgeon, a military surgeon, and he was quite skeptical towards the volunteers, and he would sit on the bench, and it was a really sunny day, and he was observing his patients for quite a long time. And then he turned to me and said, "I am so tired. I'm exhausted." I think it was the first time he ever talked to me. And I guess the first time he really saw me. And he asked, "Where is Ivan?" Ivan from the second room would benefit from being here as well. So at that moment, it was a big mindset shift for me, and it was just the beginning. I realized that providing care for mental health is not just about counseling. Later on, I met some of the management of the International Standing Committee for Mental Health and Psychosocial Support. And in the document, because I worked in an organization that was implementing and operationalizing these guidelines on MHPSS, you see the girl in this Ukrainian version of the manual of the guidelines. She is from Drushkivska, Kramatorsk, and Zaporizhia, from the east and the south of the country. So there is a Ukrainian version of these guidelines. So the term mental health and psychosocial support, this is where I encountered the term. This is something I began observing and something I could follow. And there are key principles, which I will not name, but one of the guiding principles are multi-level support. What is it? The core of the principle is that people are influenced by various factors and therefore require various types of support. So care should be provided at multiple levels, and the support needs to meet the needs of various groups. In my talk, I will refer to this intervention pyramid. It doesn't have to be the standing committee pyramid. It can be the minimum service package, because these various levels match a lot. So what is this principle about? Well, in a nutshell, every person needs basic services. And it's important that these services are safe, socially appropriate, and are delivered decently. So if people have these services, people can cope. Then enhancing the support for community and the family, so that children, women, various peer support groups are in place. And it's going to suffice for several groups of people. Also targeted or interpersonal non-specialized support. This is where the most of the interventions mentioned today fall. They fall in this category. And only a few people would actually require specialized services. So this is a general outline of the interventions pyramid. We can refer to it when we need to realize where we fall if we work in the MHPSS field. Let me give you a number of examples. I've already given you one from this military hospital, and the situation made me wonder. I'm a professional. Where is my place? What can I do? As Professor Young mentioned in his talk, there are several guidelines that mention intersectionality, that mentioned mental health. So us as professionals, where is our place here? It's basically almost anywhere. I'll give you another example. For example, needs assessment at a major center that received Ukrainian refugees, the mental health needs assessment, that is. So I arrived there at the center and I started looking at toilets. Are they in place? Are they clean? Is there a safe place where people can get warm? Are there telephones at the center? Are the SIM cards provided to the refugees? And people say, but hang on, you need to assess mental health needs. Why are you looking at information? Why would you need telephones or the number of toilets? Why would you need that information at all? But keeping in mind the interventions pyramid, we realize that these are the critical services. For example, as mental health professionals, what were my activities? The government of that country provided excellent contact details, information, but there was a huge board, but it was obscured by the bus, and this billboard was not visible, and I did not talk to the management that the buses should not be parked next to those information boards. So we wanted to talk about safety a lot so that some dodgy transport companies would not be contracted for bringing the refugees. We talked a lot about sanitation so that people could have actually decent toilets, so that people can brush their teeth there or wash their face. These are bare necessities, but they also are linked to mental health.
And if we work at the first level of this pyramid, we can also look at in which environment the service is provided. And I really liked that Professor Joop said that many people provide first psychological care without even realizing that this is PFA. It's just some natural empathy and support. And we need to look at how this care is provided, how this aid is given. For example, I've been observing the interactions of people who are refugees, IDPs, and those who are providing services. And I remember very well that there was this small, I would say, girl or young woman. And then there was quite a serious delegation inspecting things. And she was there and she stood across the entrance into her tent and she said, I will not be letting you in because the woman is breastfeeding a baby inside. And it was important for her at the moment. And then I asked her, oh, have you been trained in PFA? She said, no, I wasn't trained anywhere. I'm just here volunteering to help. So yeah, we look at all aspects. So if we talk about the second level of the pyramid, this is strengthening the community and family support. At this level, personally, I didn't work as much, but it's great to know that these services are there, that there are these places for children, that there are some peer-to-peer groups for men and for parents. It really also matches the minimum service package. And here, we're also spreading the key messages. Talking about the third level of the pyramid, this is what Irina asked me about, and here I am. Finally, this is training, what we can do. We can provide the service ourselves, like PM Plus or Self-Help Plus, and also we can teach other trainers. We know that these interventions sometimes can be done by laypersons. And I would like to share this picture on the right is our training we conducted in summer 2022 when I was a co-trainer at the TOT on Self-Help Plus. So I want to highlight here that at that stage, in our experience, we saw some serious resistance from practitioners, from specialists. They were reluctant. Oh, how can we train lay people in such a short time? So they had lots of doubts about that. And then, like, 5 sessions, how do you do it? If you talk about PM Plus, like, how do you provide these 5 sessions if people are moving, if they're migrating, we'll be seeing them again? So we have lots of experience. I see colleagues from Medicos del Mundo who are training other trainers in PM Plus and SH Plus. So they were those who tried to actually implement all these interventions in smaller villages in Luhansk and Donetsk Oblast. So we already have some accumulated experience from local Ukrainian circumstances. And indeed, it took years of implementation. So we've had some successes, some things were not successful. And if we talk about doing what matters in terms of stress, that intervention has been translated quite a long time ago, but scaling up, well, scaling it up for the level of the whole country, I mean, it was possible. It became possible only after the full-scale invasion, even though, well, it could have been done even before that. So this role of the psychologist is important. And yeah, I'll be wrapping up. So this 4th level, the specialized service, and some of us are present only there. We provide specialized trauma-focused therapy or work with other disorders. What else we can do here? We can do advocacy and establish linkage with specialized service providers. Mostly, it's the doctors, the psychiatrists, who were quite critical to these interventions. And I'm talking about, say, scaling up PM Plus or SH Plus. And I've seen colleagues who were present at the project summary meeting where we were presenting first results of PM Plus and Luhansk Oblast. And one of our esteemed regional psychiatrists, he said, "This is just toys. It all is meaningless. It's just entertainment, nothing more." So it takes lots of work to communicate with other specialists to show that we are actually strengthening the capacity of each other. And of course, sometimes it happens that things we think are obvious for us are obvious for the others, but it's not always so. I would like to share one more example from the country which also experienced war. And here I'm talking about this 4th level of specialized service provision. So there was this idea that all the victims, all the veterans, all the people who were somehow victimized or had family members killed, the government will pay for specialized mental health services. So they calculated the number of families, and it's been unprecedented. It's been unprecedented that the country is paying for specialized service. They allocate funds for a number of sessions. So they had this idea that, once again, if we can affect it, knowing about the whole pyramid, about all the levels, we can think, is it
Mm,
a correct decision when we invest only in specialized service, but in that country, for example, at that moment, back then, they didn't have these scaled up interventions, and they didn't have many community and family level interventions. I also would like to mention a little bit about this individual counseling. If we talk about this fourth level, what's important is that sometimes we, as specialists in Ukraine, we come from different backgrounds. We have different degrees, different professional experience, and sometimes we are not ready to encounter some things. What do I mean? Sometimes the person you work with would drop out. They have to be ready for this. We have to be ready to provide the intervention even within only one session. Some organizations, they have protocols for this. But if you don't work in this specific area, if you don't have these one session protocols, then like we just have to be ready that it happens. This is a reality in these situations. And if we are not certain that we are doing the correct thing, then it might be better to not do. So our role as specialists is also about awareness raising, so that we or service providers, especially in those places where the profession is not fully regulated, and in Ukraine, I would say it's not fully regulated, then we need some advocacy so that possibly harming services would not be provided. If it's one session, it can be psychoeducation, stabilization, and I really recommend to watch the recording of one of the webinars. Irina, could you please remind me? There was Professor Hopeful there, and he told about these five main elements of urgent care. So I really recommend to watch that specific webinar. If we talk about the context of individual work, and like if you read English, they quoted a very interesting article. I think I have to wrap up, Irina, right? So just lastly, I would like to say that one of our roles is communication. So we have to communicate properly, but besides that, we have to advocate non-harmful communication. I have quite a lot of examples, like we have to avoid assumptions that everyone is traumatized. And we can talk to journalists, to different officials that, well, it's just not true. Not everyone is traumatized. Also, that psychological distress is widespread and natural. People respond differently and they require different forms of support. And we should avoid highlighting PTSD when we talk about epidemiological prognosis. Yes, PTSD is prevalent, but it's not the only thing. And lastly, my last slide is about self-care. This already was discussed in some previous webinars, but in Ukrainian reality, I want to highlight that, well, it's just as basic as brushing one's teeth. Like, we have to dedicate 5 to 10 minutes a day to take care of oneself. And the very last slide is sometimes when we do these training sessions, we put these the clothing bags, and people put up papers where they write some tragic or heavy events which happened in their community. So this clothing line almost always is full. Every community has its experience of different heavy situations at different levels, at national level, at the level of a region, or even a local settlement or community. So humanity has its history of different events, but the impact of those can be compensated. So we have to develop systems considering the different needs, and then we can have the strategy and adequate response, and then we can reduce this impact.
Maybe we can ask Joop as the first one to comment maybe on Lidiia, Irina. Joop has been listening in very carefully, and maybe Joop, if you have a question or a comment or a reflection to what you heard Lidiia present, would you be able to share?
Yes, I'll try. What intrigued me, Lidiia, is that you went all over the pyramid from the bottom to the top, and you shared some of your personal experiences, and you also talked about your own development as a psychologist in a humanitarian context. What, in your opinion, what would be the most important thing for Ukraine and our Ukrainian colleagues to do over the next few years, would be my question.
Дякую за запитання.
Thank you. Thank you. That's a good question. And it's complicated. I think that one of the things we could do, one thing that's important to do, is to build up on the experience and the strength of Ukrainians who have the experience of coping and who have both the traditional experience, I mean, some traditional ceremonies. We have quite a lot of coping culture, I would say. And if we talk about this experience, the war goes on, well, and it actually goes on for almost 10 years. So it's 10 years which also cover some professional experience. So we can reinforce existing things and probably regulate it at a more systemic level. I think I would stop here, because we can do lots of things at different levels, but yeah, this probably is it.
Thank you. Erik?
Yeah, thank you, both of you. This is a perfect timing to allow the participants to chime in, to either both you, Joop, but also to Lidiia. And we do have 10 more minutes. It's late in the evening. We all appreciate the fact that you're still there, but we've heard two very eloquent contributions on a very abstract, but also a very pragmatic style. Please reach out. Irina, you raise your hand.
Дуже просте практичне питання до Лідії.
Simple practical question for Lidiia. If we want to introduce PM Plus in a small community, in how do you inform them? What would you recommend? How do you inform the local community? Answer. Assuming you already have the needs assessment in place, you did all the planning, and that implementation stage is already there. So the first step you need to do is to find people who would be assisted by this intervention to do the services they're already doing. Irina, does that make sense? You shake your hand. I'll give you an example. So for example, we find a place to do this intervention. I would meet all the people who work with the people locally. I would meet the teachers, social workers, maybe. If there's a church, I would see the priests. So anyone who works with the people in this community. So the leaders of this community who meet a lot of people, I would explain to them what PM Plus is to them. So they already are the providers of some psychosocial support services in their community. So I would like to enhance their capabilities by teaching them additional interventions. So I wouldn't want to bring some of the speakers to them. Thank you, Lidia. All right.
Yes, Sam Hunaidi, please go ahead.
Hello. Thank you so much for.
Where are you based, Sam? Just say where about or not.
Oh yes. My name is Sam Hunaidi. I'm a psychosocial support and mental health trainer and supervisor. I often work with International Medical Corps. Currently, I am in Ukraine, in Kiev, and I also have been working. I work with the research investigating PM Plus with the Strengths Project. At the FU in Amsterdam, often worked with Irina as well, with the URISE project. I have two questions. One question for Professor de Jong and one question for also Professor Lidiia. Thank you so much for both presentations. Professor de Jong, you mentioned the lack of family interventions, and we see it very often in the field. There are a lot of available group interventions now in terms of scalable and low intensity interventions and individual interventions, but family interventions, not so much. Up to my knowledge, I have to say we've all only been seeing like multi-family approach as a very, very brief intervention to apply, but are there any interventions that are being developed to your knowledge to include families, to work with families, especially we see a lot of needs amongst families of children with special needs or people with disabilities and physical impairments. So yeah, I'm just curious to hear if you know of any interventions are being developed. My question to Lidiia would be about implementation of PM Plus. I am also I am a trainer in PM Plus, and one of the challenges that we are facing, and it raises concerns to us often, is regarding supervision. So we know PM Plus helpers to ensure they have fidelity to the project, but also they are not doing any harm. They have proper supervision. A lot of times in the field, we are seeing people working as helpers, and when we check what they are doing, they are not really following the protocol of PM Plus, and there's a lot of improvisation, and this risks a lot of harm. On a big scale of implementation in Ukraine that you have been working for years now, how are we ensuring that all trained helpers have the appropriate supervision, quality supervision that they need, and the quality support for that? Thank you so much. I hope I didn't take much time.
Two great questions, Sam. Let's first listen to Joop. Professor de Jong.
Yeah, Sam, thanks a lot. I like your face and your radiation. I'm sure that when I would be depressed during this war and I would get into your consultation room, I would feel much better the moment I would enter. To get to your question, yeah, there is a big problem with family interventions. And what you see, in fact, is that there is a kind of a gap between September 11 and what happened in New York at that time, and what Trudy Moore, she's a professor of child psychology in Utrecht, what she has been developing over the past years. And she has been working on family interventions, and she has been experimenting with them on the West Bank in Palestine. Who has been also working on the West Bank in Palestine, and that's with families with children with disabilities that you mentioned, is a woman. She has a Dutch name and she has an Arab name because she was married to a Palestinian journalist, Joke Vermeulen. But since you hang out here in Holland, you know now how to spell Dutch names. So Joke Vermeulen has then done her PhD on these family interventions with disabled family members on the West Bank as well. Jack Soul, he has worked on family interventions after September 11. He's a psychiatrist from New York, and who has done very interesting family work also in the United States is Stephen Wine. So he's a professor of public health and he's a psychiatrist in Chicago University. And he has developed an intervention which he called the cafe intervention, like the cafe you drink. And he has developed that in Chicago with Bosnian families. So he got Bosnian families to a kind of a social therapeutic setting where they came together and where in fact they discussed all kinds of issues that had to do with trauma, but they also exchanged their coping strategy of how you survive as a refugee in the US. And I think that if you take his concept in a very loose way and you improvise, you shouldn't try to copy it, but improvise what he does and what Irina has been talking about before, I think you get quite far. But in a nutshell, it's true, there's still a need to further develop this. And you can also do that yourself, by the way, huh? Because the advantage of systemic family therapy is it's a very chaotic world. And everybody who's able to kind of get order in that chaos is a help in that field. Good luck. Yeah.
Thank you very much. Thanks a lot.
Thank you. Let's move on to the second question. We have maybe a minute or two, three. Lydia, could you pick up on the second question from Sam?
Так. Я буду
Yes.
українською.
I'll reply in Ukrainian.
Я працювала також з військовими
I
медиками.
also
Вони
worked
дуже
with
чітко
the
мене
battlefield medics, and this is what they taught me.
Планування попереджає погане виконання.
To prevent poor
Я вже жартую на кінець
execution, you need to plan for things correctly. A joke at the end of the meeting. So why were we successful? Because we could plan ahead. We had that luxury. And as part of that planning, there was a separate person who was responsible largely for supervision on PM+, and this person was attending today, the woman supervisor. I think she was here today. So we allocated funds for this person so that it's a paid job, so that that person could attend the presence sessions. We even had presence sessions. So all the trainees after one session could do a 10-minute call, and it was a very structured conference call, and the supervisor would attend. And one of the 5 sessions had to be in the presence of the supervisor. And this was a condition for us to give the certificate. And there was the number of clients, the number of hours. Obviously, it was done to motivate people, to ensure that they have their certificates only after these supervision sessions. But the reason was exactly as you say, Sam. There were a lot of people who were extremely creative in the way they approached it. There was a lot of improvisation, and this creativity wasn't always helping. So that's why we structured it with the a conference call with the supervisor and also a session in presence of the supervisor. Thank you, Lidia.
Я можу ще трохи прокоментувати чат, перш ніж
I can comment on something that was in the chat and then we can wrap up. I see many appreciations both for our speakers and the organizers for organizing, and also some words of thanks to our interpreters. They're excellent. I said it in English. Oh my God, I even forgot the Ukrainian word for excellent. Yes, we thank them for excellent interpretation. We also have a comment from Andriy. He says, unfortunately, the red tape is an impediment for implementing interventions, especially when it comes to implementation level, and we cannot ignore that red tape. This was not the topic of our discussion today, however. What we need to know that it exists, and maybe once this would be something that we'll discuss in the future. I also see loads of questions. How can I attend a PM Plus training? I will not announce everything. I know that we are planning, and it's not just us, but other people who are here today are planning things. So we will let you know as soon as we can.